Good morning, everyone. The topic for today's presentation is hyponatremia in psychiatry. I am Dr. Shambhavi and my moderator is Dr. Tanya Garg. Hyponatremia is defined as serum sodium levels less than 135 millimole per liter. It is one of the most frequently encountered electrolyte imbalances in medical practice. If severe, it represents potentially life-threatening medical emergencies resulting in seizure, coma, and death. The most significant risk factor for derangement in sodium level is increasing age. Psychiatric patients represent a vulnerable cohort for hyponatremia. For example, abuse of laxatives and diuretics in patients with eating disorders may result in excessive GI losses of sodium. Several psychiatric drugs like antidepressants, SSRIs, antipsychotics, and mood stabilizers can cause syndrome of inappropriate antidiuretic hormone secretion, resulting in hyponatremia. Furthermore, patients with serious forms of mental illness may present with psychogenic polydipsia, thus leaving them vulnerable to electrolyte imbalances. Crucially, electrolyte imbalance itself may manifest as an organic cause of psychiatric symptoms such as depression and anxiety. Eating disorders are characterized by disturbance in eating or eating-related behavior and body image associated with substantial distress and psychosocial impairment and or jeopardizing physical health. For example, anorexia nervosa, bulimia nervosa, binge eating disorder, avoidant restrictive food intake disorder, pica, or rumination disorder. Psychotic illnesses, bipolar illnesses, and obsessive compulsive disorder affecting serum sodium. Psychotic illnesses, one of the most common psychotic illnesses that affect serum sodium is schizophrenia. Patients with schizophrenia can experience primary psychogenic polydipsia. It is hypothesized that this occurs in patients with schizophrenia due to the elevated levels of dopamine that stimulate the thirst center. In patients with schizophrenia, polydipsia prevalence is estimated at 6 to 20%. Bipolar illness, psychogenic polydipsia also has been implicated in psychiatric patients with bipolar 1 disorder in a maniac state, whose increase in fluid intake can lead to hyponatremia. Obsessive compulsive disorder and urge to drink excessive water leads to consumption of large amount of water, producing hyponatremia and seizure. This is important because it highlights how a psychiatric condition can present as a neurological emergency. Common causes of hyponatremia. Hypovolemic hyponatremia. Common causes are cerebral salt wasting, in-head injury, intracranial hemorrhage, use of diuretics, GI losses due to diarrhea and vomiting, primary Addison's disease, secondary pituitary failure, and tertiary cause hypothalamic failure, mineralocorticoid deficiency, osmotic diuresis in case of diabetic ketoacidosis, renal tubular acidosis, third spacing, bowel obstruction, or burns. Euvolemic hyponatremia, 3,4-methylene dioxymeth amphetamine ecstasy consumption, beer potomania, glucocorticoid deficiency, hypothyroidism, psychogenic polydipsia, syndrome of inappropriate ADH hormone secretion, water intoxication, hypervolemic hyponatremia, congestive cardiac failure, cirrhosis, nephrotic syndrome, renal failure, acute or chronic. Mechanism of drug-induced hyponatremia, SIADH, increased levels of antidiuretic hormone causes the renal tubules to become more permeable to water, which causes more water reabsorption. So urine volume decreases and urine osmolality increases, causing an increase in the urine sodium concentration, which decreases due to water reabsorption. The level of aldosterone also decreases, and blood volume increases, serum hypoosmolality increases, and dilutional hyponatremia causes the following symptoms: anorexia, nausea, vomiting, irritability, confusion, hallucinations, and seizures. Symptoms of hyponatremia are confusion, sluggishness, headache, fatigue and low energy, and nausea and vomiting. Diagnostic principles. Hyponatremia is often asymptomatic. Symptoms only occur in severe derangement. Management is based on identifying the precipitating factors, detailed history, and examination. Following points should be kept in mind while asking the history from the patient, quantify the recent water or fluid intake, presence of thirst or reduction in urine output, recent diarrhea, vomiting or constipation, weight loss or other red flags of malignancy like dysphagia and uh, deranged bowel habits. Features of adrenal insufficiency like hyperpigmentation, presence of neurological symptoms like confusion, headache, and screen for comorbidities like congestive cardiac failure, cirrhosis, or kidney failure. Drug history, diuretics, laxatives, steroids, or psychotropics or anticonvulsant drugs and antidepressants, they all cause hyponatremia. Risk increases with the use of antidepressants in old age, or if the antidepressants are used with thiazide diuretics. Only meancerin does not increase the risk. A quick screen can be utilized to investigate eating disorder patterns. Clinicians should use a validated eating disorder questionnaire like the Eating Disorder Questionnaire online or the Sick Control 1 Fat Food Questionnaire to assess for the presence of an eating disorder. Examination includes assessment of the level of consciousness, heart rate, blood pressure, respiratory rate, oxygen saturation, and blood glucose. Underlying pathology by determining the fluid status can be determined. Cachexia can point towards malignancy or any eating disorders. Abdominal examination for constipation or changed bowel habits on liver dysfunction, and thyroid examination. Investigation includes blood electrolytes, urea and creatinine, serum lipid and serum protein levels, because increased triglyceride and protein levels have known to cause wrong lab results, which is known as pseudo hyponatremia. Serum calcium levels, glycosylated hemoglobin levels, lithium levels, brain natriuretic peptide if heart failure is suspected, LFTs, and check serum osmolality compared with urine osmolality and sodium levels. For example, SIADH is characterized by decreased plasma osmolality, increased urine osmolality, and raised urinary sodium levels. Early morning urine osmolality, if the urine osmolality is more than 400 milliosmol per kg, it includes severe diabetes, it excludes the severe diabetes insipidus. In urine, we have to distinguish between polyuria from increased urinary frequency. If diabetes insipidus is suspected, give the patient 2 collection jars as they may produce an excess of 8 liters of urine. Urine dip test for proteinuria, glucose, and ketones are done. Hyponatremia, we have to exclude the hyperglycemia and other causes of non-hypotonic hyponatremia. Hypotonic hyponatremia, if acute or severe symptoms are there, then consider immediate treatment with hypertonic saline. If they are not present, then we have to do a urine osmolality test. If it is less than 100 milliosmol per kg, then consider the causes such as primary polydipsia, low solute intake, or beer potomania. If the osmolality is more than 100 milliosmol per kg, then we have to do assessment of the urine sodium. If it is less than 30 millimole per liter, then low effective arterial blood volume indicates ECF is expanded, then consider heart failure, liver cirrhosis or nephrotic syndrome. If the ECF is contracted, consider diarrhea and vomiting, third spacing, or remote diuretics. And if the urine sodium is more than equal to 30 millimole per liter, then if the patient is on diuretic, then consider that diuretic may be the cause. And if he is not on diuretics, then ECF contracted, consider vomiting or primary adrenal insufficiency, renal salt wasting, cerebral salt wasting. If ECF is normal, consider SIADH, secondary adrenal insufficiency, hypothyroidism, and consider occult diuretics as the cause. Management, it is recommended that management of acute hyponatremia, severe hyponatremia, or symptomatic hyponatremia occurs in a general medical setting. These patients require careful monitoring of electrolytes, controlled use of fluid resuscitation or diuresis, and management of the underlying pathology. An important clinical pearl is to correct the sodium level by no more than 12 milliequivalent per liter in 24 hours or 18 milliequivalent per liter in 48 hours. This is done to prevent the life-threatening complication known as osmotic demyelination syndrome, which is characterized by cerebral edema. Mild hyponatremia in stable patients may be managed in a psychiatric setting according to the clinician's experience. Where antidepressant treatment is necessary, strongly consider stopping the concurrent use of thiazide diuretics. Compared with other antidepressants, metazapine and menacerin have low hyponatremia risk profiles. Alternatives are agomelatine and bupropion. In patients with chronic hyponatremia in association with underlying conditions, referral to corresponding specialties may be of benefit. Psychogenic polydipsia may be managed using psychoeducation, fluid restriction, and treatment of the underlying psychiatric disorder. There is evidence that clozapine improves polydipsia. These are the interventions that can be done to correct dilutional hyponatremia. First of all, oral fluid restriction, then reduction of the diuretics, then infusion of albumin, and the last intervention is vasopressin 1,2 receptor antagonist. Those are called Vaptins. My references are the Maudsley Practice Guidelines for Physical Health Conditions in Psychiatry and an article on hyponatremia and psychiatric diseases. Thank you.
Good morning, everyone. Today, Shivam Garg is here to discuss about obesity in psychiatry, and my moderator is Dr. Ishani Pandey. First of all, let's talk about obesity. WHO defines overweight and obesity as abnormal accumulation of excessive fat that present risk to health. A crude measure of obesity is body mass index with BMI greater than 30 considered as obese. Obesity is divided into three classes based on EMI. Class 1, BMI ranges from 30 to 34.9 kilogram per meter square. Class 2, BMI 35 to 39.9, and Class 3, BMI 40 plus. Other ways to calculate obesity. Waist circumference is an index of intra-abdominal fat mass. Measurement of waist circumference as follows. Find the bottom of the patient ribs and the top of the patient hips. Wrap and measure tape around the patient waist midway between these points. Have a patient breathe out naturally before taking the assessment. Waist circumference of 94 centimeter for men and 88 centimeter for women are associated with high risk of serious health condition, and these patients should be reviewed by the clinicians. Obesity and mental illness. Obesity is more prevalent in people with SMIs, that is severe mental illness. Compared to general population, for example, North America study observed that 80% of sample over 10,000 people with diagnosis of schizophrenia, bipolar disorder, and depression were either obese or overweight. The cause of overweight in this population is multifactorial, including high calorie intake, genetic factors, social isolation, and negative discrimination. Furthermore, Many antipsychotic medications, as well as some antidepressant and mood stabilizers, are recognized to reduce weight gain. In addition to the burden of physical comorbidities, obesity reduces self-worth and is associated with reduced quality of life and poor concordance with psychotropic treatment. Here is the monitoring protocol for weight gain in patients with severe mental illness initiating psychotropic medications. For example, parameters such as body weight and BMI can be calculated when the patient first visit to the OPD and 4 weeks after that, and successive 8 weeks, 12 weeks, and 6 months, and annually thereafter. Waist circumference from the baseline and 4 weeks after that, 8 weeks, then 12 weeks, and 6 months, and then annually thereafter. Weight to height ratio from the baseline, 12 weeks after that, 6 months, and then annually thereafter. Spatial situation. Increased monitoring frequency should be considered in certain clinical situations. For example, adults and pediatric patients are at increased risk of antipsychotic-induced weight gain. Rapid weight gain following initiation of psychotropic medication is a stronger predictor of long-term weight gain and should prompt both enhanced monitoring and prevent or remedial strategies. It is recommended that patients with bipolar disorder and major depressive disorder undergo the same baseline assessment as those with schizophrenia when initiating treatment. Weight gain has been described in patients receiving antidepressants such as mirtazapine, mianserin, tricyclics, monoamine oxidase inhibitors, and mood stabilizers, especially valproate and lithium. Prevention and treatment of weight gain. Approach to management of weight gain in patients with severe mental illness. Baseline screening. If the person is overweight, inform and work alongside with the primary care. Non-pharmacological interventions, which includes dietary advice, consider referral to dietetic services, increased activity, improve sleep hygiene. Consider use of metformin, especially if the patient is pre-diabetic. Manage comorbidities, example diabetes, hypertension, or dyslipidemia. If the patient is not overweight, monitoring as per the table we have discussed earlier. This one. If the patient remains overweight, along with the primary care, refer to a specialized services if indicated. Consider use of pharmacological agents with evidence of aiding weight loss in psychiatric patients. For example, add on aripiprazole for olanzapine induced weight gain. Consider refer for bariatric surgery. Non-pharmacological intervention to combat weight gain. Lifestyle modification. Preventive strategies that aim to help patients achieve healthy lifestyle should be offered to everyone. These includes avoid stop smoking, addressing alcohol and substance misuse, improving diet, improving sleep, and increase physical activity. There is evidence that combined lifestyle interventions, including behavioral interventions, nutritional, and exercise, are effective in attenuating weight gain when introduced during early phase of antipsychotic treatment. Dietary advice for weight loss. Have a bowl of soup or sugar-free drink before a meal can help fill you up so you eat less. Aim to eat 3 regular balanced diet meals a day. Eat fruits and vegetables intake. Increase fruits and vegetable intake. Choose food and snacks that are low in fat, sugar, and salt. Choose drinks that are sugar-free and low fat and are fat-free. When eating, make this only activity you are doing. And that is no TV, no social media, and no phone should be used. Eat slowly, take your time, and enjoy your food. When eating, aim to eat at table rather than on a couch or a table. Pharmacological interventions. The best evidence for pharmacological management of weight gain in patients with severe mental illness is use of metformin. There are various other agents also available, in which includes glucagon-like peptide, aripiprazole, amantadine, bupropion, topiramate, and zonisamide. Currently, there are 10 FDA-approved anti-obesity medication in the US, which includes phentermine. Can I skip? Management of comorbidities. Other components of metabolic syndrome, for example, hypertension, type 2 diabetes, and dyslipidemia should be managed to decrease cardiovascular risk. When referred to a specialist, primary care practitioner should be informed from the onset and should be involved in discussion regarding the patient weight and associated metabolic disturbances. Where available, referral to a dietitian should be considered as well as supporting improved access to physical activity. Bariatric surgery should be considered for patients with both pharmacological and non-pharmacological strategies. Overview of bariatric surgery. Bariatric surgery, also referred to as weight loss surgery, refers to a group of surgical intervention designed to reduce body weight and improve obesity-related conditions. Common type of bariatric surgery includes the following: gastric bypass, in which top part of the stomach is joined with the small intestine; sleeve gastrectomy, some of the part of stomach is removed; and gastric band. References: Maudsley. Thank you. Ma'am, can I end meeting?